Welcome to the 4th episode of PKRG-TV's Well-Being series. I am Trevor Dublin, and we are honored today to have as our guest the distinguished cardiologist and internist, Dr. David Fridman. Dr. Fridman's practice at One Heart Health, located in Cliffside Park, specializes in geriatric cardiology with an emphasis on preventing disease by encouraging his patients to maintain a healthy lifestyle. Dr. Fridman also has a unique practice model which focuses on delivering in-home cardiac care. Through regular house calls and facility visits, Dr. Fridman and his dedicated team provide comprehensive cardiac care to those who struggle to access medical care. Today, Dr. Fridman will share his insights into how viewers of all ages can take responsibility for maintaining and enhancing their well-being and quality of life through exercise and diet, as well as by becoming mentally prepared to manage life's inevitable health challenges. He'll also help us to understand why a careful assessment of the benefits and the limitations of medications is so important as part of a multifaceted approach to treatment and prevention, one which ideally incorporates a collaborative team of medical providers. I've had the great pleasure of getting to know Dr. Fridman and his life-affirming work during his regular visits to care for patients at Maple Glen Center, where I serve as the administrator. So I especially am delighted to be able to welcome him to our program. Dr. Fridman, thank you so much for taking the time out of your busy schedule to share your thoughts with us.
Thank you for the warm introduction, Trevor. I'm definitely looking forward to today's discussion.
Dr. Fridman brings a wealth of experience to his patients and their families, and he's been awarded several honors and academic distinctions, including board certifications in cardiology and internal medicine. So get ready for insightful discussions and a deeper understanding of innovative approaches to better health and well-being. So Dr. Fridman, it's really a pleasure to have you here today. And
thank you.
So the first question I think I have is just, what exactly is a geriatric cardiologist, and how does their training and practice differ from the training and the practice of a regular cardiologist?
That's a very common question, and it's a great question, because I think when people hear the term geriatric cardiologist, there's often a sense of redundancy. I think that many patients and many people, when they hear cardiologist, they assume that we're taking care of an older population of patients, and what exactly does it mean to be a geriatric cardiologist? And I'll outline a few key distinctions. I think professionally speaking, a geriatric cardiologist is very akin to what you would see with a geriatrician, where the fundamental knowledge of internal medicine is there. It's just the application and the patient population that's a bit different. And in my world, just to give you an example of what that entails, is when patients are generally coming to me, the cardiac component is generally just one of multiple ongoing issues. So in my world and in the medical lexicon, the term of a multidisciplinary approach is very important. And what I mean by that is there are often many providers that are involved in the patient's care. And providers in my world span from home health aides to family members to other clinicians, physical therapists. So all these players are very important in the patient's care at that moment in time. And because of that, all our decisions are very much intertwined. And what that entails is a real-time ongoing discussion about what's going on with the patient. And that is in contrast to what I think most people experience when they encounter their healthcare professional. So for example, a patient may see one or two providers over the course of the year, and maybe the first provider may make some changes, and that doesn't necessitate an immediate conversation with other providers. Their note might be faxed, or the patient may fill in some of the things that were changed at the follow-up visit with the other provider, and that works for that type of patient population. But in my world, because of the complexity, the conversations often begin before I see the patient and then shortly after. And because of that, it's a different type of skill set and approach. In terms of the actual training, I would say that geriatric cardiology is an emerging type of field There are a few fellowships that are offered where they try to specialize the cardiology training for the geriatric population, but it is very much an emerging field, and it's something that needs to be learned and appreciated, and it becomes more and more important because in America the population is slowly aging. So the application of the same knowledge set is very important, particularly for the older and aging population. I think those are the key fundamental differences.
That's great. And it sounds like it's also like a very interdisciplinary sort of approach, because you mentioned, the therapists that are involved, physical therapy, whatever
Correct, yes.
that may be needed. So it's, not just yourself, but there's others that are supporting what you're doing as well.
Yeah, there's often more to the picture, and you can't quite capture everything within the span of one patient interview. So hearing what the clinician that referred the patient to me has to say, and then hearing what, for example, a home health aide who may spend a lot of time with the patient or a family member that's very much involved with the care is supplementary, complementary, and often kind of dictates the course of action from my end. So again, it's a very different type of world. It's very collaborative, and it's not necessary for all circumstances, but in the world I'm in, it's very much part and parcel to how we provide care.
Okay, great. Since most of your patients are older, what are some of the challenges you face in helping them to develop and maintain a healthy lifestyle? And how do you help them to overcome obstacles to achieving better health?
So there are a lot of challenges. It's a topic in and of itself, but just to touch upon what I think is probably the most prevalent and most important one is physical limitations. And this is really where the interdisciplinary model shines through. And to the point I brought up earlier, where it's difficult to always parse out what the ongoing issue is when the patient sees you, rather not the ongoing issue, but what the culprit mechanism is for the problem at hand, you really need to hear the story globally to get a sense. And I can give you some examples of that. There may be a patient that's being cared for by a provider that has noticed that, over the span of the past 6 months or a year, there's been a lot of gait instability, or maybe some difficulty with walking or some pain with walking. And the consult for me is one of shortness of breath. It could very well be that that patient's shortness of breath is from debility, decreased muscle fitness and strength, and they're getting short of breath. But the culprit or the real problem is their hip, and their hip may need to be seen by an orthopedist. And it could very well be that if we do injections or a hip replacement, that can liberate the patient and really help them thrive as much as possible. And that is, again, part of this interdisciplinary approach. And it is often a pain point when patients come to the office. And in regards to physical limitations, they come in a variety of forms. There can be complaints about muscle soreness, joint aches and pains, fatigue, and then more classical symptoms such as shortness of breath. And in each one of those situations, it's very important to parse out what is the real mechanism. Sometimes there's more than one moving pieces there. A lot of times there's just one thing that needs to be addressed. And that's kind of the role that I play amongst the broader providers in helping sort out the course of action and what type of workup needs to happen in order to parse out what we should be addressing first. So I think those are kind of the highlights. And then also medications. If I'm going to list things in order, physical limitations is definitely up there, but also medications and all the problems that are embodied within medication adherence and compliance, and also just a patient understanding or family understanding the role of medications at that particular point in the patient's life. So medications often can be optimized, and it really requires a thorough evaluation of the medications the patient's taking, and also a conversation with the other clinicians involved to understand where and how the medications are helping or potentially creating problems. Some of the problems we see with medications are the adherence factor. There are patients that take medications once a day, some take medications twice a day, and there are even medications that are dosed 3 times a day. Medications can be optimized from that perspective to make them, for lack of a better term, user-friendly. And that's very important. The other portion of medications, which I think is often forgotten in the office setting, is educating the patient about what they can expect from that medication. So something that I commonly do during the visits with my patients is give them an understanding of the mechanism of the medication and what they can expect from the medication. Because the last thing I want in terms of the medication regimen is patients having an exaggerated expectation of what can be accomplished if they take a medication. But I also don't want them to have an exaggerated fear if they feel they want to discontinue a medication. And that requires some understanding and educating patients so they understand why and how and when they should be taking medications. And that's part of the effort and challenge that we see with a lot of patients. So I'd say in terms of the top two, the physical limitations and also medication in all that broad scope are very challenging and something that we try to strive our best to help improve in patients.
Medication management. And
medication management, yes.
Yeah, that's awesome, yeah. I know that a lot of doctors concentrate on treating patients after they become ill, right? Mm-hmm. How does your approach to well-being differ from the more commonly encountered medical management philosophy?
That's an excellent question. So I think what you're trying to get at is preventative medicine. Mm-hmm. And preventative medicine is often thought of as an application or an approach that you do early on in life. But the reality is that preventative measures can be taken on in all phases of life. And it can really start from a variety of factors. And the most preeminent one, the one I think is probably up there, is understanding the importance of exercise and physical fitness. So when we're dealing with preventative measures, that is often the top of the conversation when I'm seeing a patient. And it's important to understand who the patient is sitting in front of you. The recommendations that I would make, for example, for a 75-year-old patient versus a 95-year-old patient is clearly going to be different. But of course, age is just a number, and there's a lot of variability amongst patients' capacities at different ages. But you have to get that understanding, and that also is where that interdisciplinary model really helps, because you can get a sense of what the capacity is of that patient when they're sitting in front of you and what they can realistically accomplish. So that is something that's important, something that we address at each visit. And in regards to exercise and general fitness, it's always important to highlight that in and of itself, the performance that one can expect and the outcomes one can expect from medicine often mirrors that of what medications can accomplish, and sometimes can exceed what medications can accomplish. And just to say, it doesn't mean that people shouldn't be taking their medications, but physical fitness is certainly a complementary non-medication way that someone can optimize their health, and is something that really needs to be emphasized at each visit. And there's a variety of different ways I think we'll go through that patients can optimize and engage in physical activity so that they can optimize their health overall.
So it's never too late to exercise, it's never too late to pick up, because sometimes I think as people get older, that's when I was younger, but you can pick it up at any place and you will see some benefit, correct?
Correct. And there's a lot of crafty ways that one can devise an exercise regimen. And it's really important to understand this one thing, and I mention this often during the office visits. If I'm giving you a cholesterol medication, you probably do not feel your cholesterol lowering. You just not a tangible or feeling that you have with taking the medication. However, exercise will evoke a feeling. You just have to give it a few weeks. Everybody, if you were to measure objectively their amount of how much they're able to achieve, whether it's walking, jogging, something they do in a chair, all these things can be monitored, and given enough time, meaning giving the muscle enough time to acclimate and adapt to the stressors through the physical fitness regime that you're going through, you will actually see the benefits, and it happens in a relatively short amount of time. So that can be a few weeks, 4 to 6 weeks. And it's something that's often motivating and reassuring, and it's something that can be felt and seen, which I think has a very potent stimulus for patients once they get into it.
So the next question I have kind of maybe just ties in a little bit what the answer you just gave, but you can probably elaborate. So what role can patients play in prevention of cardiovascular disease and in maintaining and enhancing their health and well-being? I know we talked about exercise, but what else can they do?
So there's a lot of intuition, I guess, that we have in terms of what's good or bad, but it always helps to visit your providers and have regular follow-up. Having regular blood work, regular assessment of your medications, all those things are important. For many of my patients, I'm seeing them maybe 3-4 times a year to go over all those things. Having an open line, a direct line of communication is also very important, so that you understand at junctures in life where things need to be titrated and optimized, whether it's from medications, from recommendations for certain procedures, or from other avenues. You really only have that if you're in a constant dialogue with your providers. So I think not to be forgotten that you have clinicians out there that need to be seen, and through regular follow-up, you will have the necessary guidance to help optimize everything in addition to your efforts at home.
Okay, awesome. Most younger people have at least some sense of the type of exercise that is right for them. and which they enjoy most. But the older folks, many of whom have some degree of mobility impairment or some limitations, what are some of the things that we can do to maintain and improve, their overall well-being despite, such impediments?
So it's a great question. So it's a very common question. So adapting a fitness regimen that is going to be useful and actually something the patient can engage with is a common topic of conversation. And that's one that's often had with the physical therapist. One of the items that I often recommend if there are mobility issues is first trying to understand, what that issue is, and if that issue itself needs resolution, because again, there's much more you can do if you can mobilize in terms of exercise and the types of things you can do in terms of physical activity. But if there is limitations, one of my favorite exercises is going to be the recumbent bike. And the recumbent bike is a specific type of bike. I think some of us have seen it if you have access to a gym. And it's kind of like a chair that you can sit in and pedal away.
Oh, okay.
And one of the utilities of that, it takes the weight off of your joints. So you'd be surprised with taking all that burden off your knees and hips, you actually could engage in a cardiovascular exercise, get your heart rate up, breathing goes up, and you can actually benefit from that type of exercise without the necessary aches and pains that are attributed to it if you have joint-related issues. There's also cycle ergometers for your arms, which I think people forget. They also have arms that can be exercised, and people quickly realize how deconditioned their arms can be once they start exercising and trying to use their arms in a way that's very different. Usually you think of a cardiovascular exercise as running,
right.
But if you were to apply that type of therapy to your arms, you realize that there's a lot of optimization that can occur through simple exercises using your arms and how easy they fatigue. And it's also a really crafty way that you can exercise. And then there are other exercises such as chair exercises. There's a lot of programs out there I won't plug here, but there's a lot of resources out there for doing chair exercises that are obviously low impact and can produce benefit. There's a variety of other modalities, but I think those are the key ones that I would highlight.
What's an ideal goal of the amount of time someone should spend exercising each week? And what do you suggest to your patients who find that exercising causes them to feel short of breath or fatigued?
So in the medical literature, the recommendations are fairly broad, but the specific ones that are released by the American Heart Association are 150 minutes of moderate intensity exercise or 75 minutes of high intensity exercise. Let's focus just on the moderate intensity exercise portion because it's intuitive and I think most people can get to that point. And that 150 minutes can be distributed over a week. So I often tell people 5 30-minute sessions, which I think most people can carve out in their day.
Doable.
Yeah, it's very doable. And what moderate intensity exercise means that if Trevor and I were speed walking or doing some sort of exercise activity, our heart rates are obviously going to go up. We're going to be breathing a little bit more deeply, a little bit more frequently, but not to the extent that we couldn't hold a conversation. And I think that's a very important key, that if you're exercising with someone, you'd be able to complete most of your sentences. And that's in contrast to a high intensity exercise where, for example, sprinting or basketball, where once you're in it and you're trying to have a conversation, you're probably breaking up your sentences with extra breaths. And that's really not necessary. You can still derive the same type of benefit, just spread out over the course of the week with smaller intervals. Now, part of that, and I think it's very important to the point you brought up about shortness of breath, if the shortness of breath was evaluated and there's nothing in the sense of an immediate cardiac issue that needs to be addressed or a pulmonary issue that needs to address, it's very important to incorporate a high intensity training ritual within the moderate intensity exercise. And what I mean by that is, if you find that you're using the recumbent bike and you're able to do 30 minutes and you're sweating a little bit, which is great. Sweating is always a great marker that you're exercising. If you're able to, within the span of that 30 minutes, incorporate 2 or 3 bursts where you really push yourself, it could be for 30 seconds, it could be for a minute, and then back down and go back into your cruise control, that stimulates muscle in a very effective way. And muscle stimulation, whether you're 5 years old or whether you're 95 years old, is how muscle grows. It's how muscle optimizes its energy utilization. So symptoms, for example, of shortness of breath are often improved as you improve your muscle's capacity. And the only way to improve your muscle capacity is to use it to some point of fatigue or exhaustion. And if you're able to give these little bursts of excess energy, you will see multiples in terms of the benefit downstream. So taking away the two key points here for the audience: moderate intensity exercise in the span of 150 minutes over the course of a week. And when you can, try to incorporate these brief episodes where you're really pushing yourself. And again, it can be for 30 seconds or a minute, and then you can back off. But doing that will really optimize the exercise you're doing and the results that you'll see over the subsequent weeks.
And I think what you're saying is very reasonable, right?
Of course.
30 minutes a day, most people can probably achieve that.
Yeah, and don't forget to sweat, all right? If you're not sweating, a lot of patients will come in the office and say, well, I walk. Walking is not exercise. Remember, the main thing for you to remember is your heart rate's going up, you're breathing more deeply, and if at the end of the 30-minute session your brow is beating up with sweat, you're exercising. But just leisurely walking is probably not going to get you the benefit. It's probably just going to maintain the muscle mass that you have. And unfortunately, if just maintenance is what you're doing, you're going to tend to decline over time because muscle does atrophy as people get older. So the only way to maintain muscle mass and improve muscle mass is to stress the muscle, and that's a very important thing to remember in your day-to-day activities.
Okay, so I have another medication related, I know we talked about that before, but just what are some of the most common medication related issues you encounter with older patients, and how do you help your patients get on the right track with their medicines?
So it's a tough thing to do, because often I feel like the seniors that I'm seeing are taking a handful of medications and just swallowing them every morning. And they're certainly dissatisfied with that. They can't understand why they're taking the medications they're taking, why they're taking them so frequently. And it really comes down to education. I think we spoke a little bit about this with an earlier question, but the most common problems are the frequency of medications, the quantity of medications, and the lack of insight as to why they're taking medications. So as we touched upon earlier, medications, particularly medications that you're using for preventative measures, the most common ones being cholesterol medications or blood thinners such as aspirin. Those medications tend to evoke an effect over years. They're not the type of medications you're going to see a benefit, for example, like blood pressure medication, where you'll see a benefit over the course of a week or two. And the reason for that, it takes time to live within your system where cholesterol is kept low, where the physiologic maladaptations we have from high cholesterol levels are actually improved. So depending on the patient sitting in front of you, if a patient has reached a certain age, it may be reasonable to have a discussion regarding the efficacy and utility of maintaining a preventative medication. Whereas if a patient may be younger and has many years ahead of them, it may be reasonable to discuss and prioritize keeping that medication on board. So that's often an important thing, and there's many medications that span that discussion, and you can discuss every medication, where and how it applies to that particular person's life. Blood pressure medication is often one of those things that's a pain point during the discussions in the office. There are blood pressure medications that are either dosed too frequently or are used in a way that's not effective for that particular patient, so they end up being on multiple medications, when you can really optimize and down titrate the medications by choosing more optimal medications that are more potent, for example. And that's often a consult that I'll have from internists, where patients may be on 4 or 5 blood pressure medications, and I can often get that down to maybe 2 or 3 medications, because I choose the medications I know are validated for that patient population through studies. And again, that's always a great thing in the patients and the providers' eyes and ears when they hear that, hey, we can actually shorten this list a bit for you, and let's just play around with these medications and see how you respond to them. So yeah, those are the key features there.
That's great. That's great. I know that psychosocial issues also play an important role in everyone's health. How do you help your patients and their families prepare for and adjust to changes in their health conditions over time?
So the conversation piece is important, and we spoke about having regular follow-up with a doctor. One of the reasons that's important is you develop a relationship. And families are, they're distinct entities, but the provider and family in the world that I'm in almost become one entity. And knowing your patients over the course of the year, knowing the family over the course of the year, really provides an open line of communication, and also a friendship where you can have an ongoing dialogue about the challenges that life throws at us as people get older. So the psychosocial aspect really boils down to the emotional components and the challenges that we experience as our loved ones age. So one thing that I can offer is insight and anticipation as to what to expect as folks get older. And that can be for their siblings or for their children. And it's important because if one anticipates problems, it doesn't catch them off guard. They can have the necessary things in place when things are needed. And you really can only accomplish that if you prepare in advance. And that's part of the reason why I emphasize regular follow-up and engaging with your providers and finding providers you feel comfortable with. Your providers should be, again, it should be like family. And one of the benefits I have from doing so many house calls, visiting facilities, nursing homes, assisted living facilities, independent living facilities, is you foster this type of environment where everyone is kind of open and willing to discuss things that would otherwise, I want to say maybe painful or difficult to discuss in a 30-minute visit in an office setting. So people are a little bit more comforted when you see them in their home. And I think it's an important way to at least broach the topics that are often more challenging to discuss. And it's a feature of my practice, and I think a lot of the clinicians that are involved in the geriatric world. So that's how I kind of open the gate and discuss those things. And I think it's very fruitful if it's done in the right way.
Yeah. And I think sometimes people are, obviously, they're very fearful. They don't know, the questions to ask, so they have to trust you, many times, and they're relying on you. Is there like a magic number or sort of like a number of medications that you would recommend that usually that, patients would stay within or shouldn't go beyond? Because I know medications, like you mentioned before, a lot of seniors tend to have a lot of medications, but
That's a difficult thing to answer because every patient carries different problems. So I wouldn't say there's a cap on medications or necessarily a bare minimum that people have to take. It's really a case-by-case basis. But in any situation, having the conversation about whether there's room for optimization should be had, and if it can be accomplished, it should be accomplished.
All right. So healthcare provision has become increasingly specialized in recent years. What things do you try to do as a physician to ensure that your patients receive coordinated care among their multiple providers?
So that's a very tough thing to do. You really have to find providers that are like-minded. So the world that I'm operating in, you really have to love what you're doing. It's not an efficient world because there's a lot of ongoing dialogue with multiple people about one individual. So you really have to enjoy it. And fortunately, there are a group of providers that I work closely with where there is a like-mindedness and an enjoyment in this type of medicine. So that is key. So you have to find providers that are willing to engage and spend the time. And those are available. You just have to kind of find them and engage with them when you can. So that is, I think, the optimal strategy, because again, it does take a little bit more effort to make those phone calls and discussions to get the information we need, like we described earlier, speaking with the home health aides, with the physical therapist, getting a sense of what we can do to optimize that individual's outcomes. And I think that's probably the key feature. It's really just coordinating care with providers that are like-minded and want to put that extra effort in.
That's great, and it's a great, as you had mentioned before, it's like geriatric cardiology is kind of like a new sort of emerging sort of field, as you mentioned before.
Yes,
so it's really exciting.
Yes.
So it used to be the case that many doctors made home or house calls to their patients, especially older patients who find it difficult to get to the doctor's office. Now, how does your practice address the challenges homebound patients face in obtaining regular medical care?
So I think, to that question, to the point that you're bringing up about house calls, it's something that I love doing. There's a long history in regards to my training, how I got incorporated into the house call world. I probably am the only cardiologist performing house calls at this time that I know of, at least in New Jersey. And it's something that is challenging because you have to bring the office with you. And if you're dedicated and you want to figure out how to do that, it's certainly possible. So there are services in regards to testing that can be arranged in home, and that can be simple things like phlebotomy services. There are companies that come out and are covered by most major payers that will do blood work in the house. Testing in regards to ultrasound testing, echocardiography, which is really a key feature of cardiology evaluation and assessment. I do a lot of my own echocardiograms, and patients find that to be very interesting and also encouraging. I do my own echoes. I actually can do a very good echocardiogram, and a lot of that's part of the evaluation when I see patients. And then simple things like EKGs, pacemaker checks for patients that have pacemakers. That's all things that I've learned to be able to incorporate during the house call. So when patients see me, it's kind of like a one-stop shop, whether it comes to blood work, arranging for other providers such as physical therapists to come see them in their home, diagnostic testing. I figured that out over the past 3 years, and I can really bring all that care into the person's home. And I think people are often very surprised about how much we can accomplish through one house call.
So you've been doing these house calls in the last 2 years, or when did it first, I guess, when did you decide to make that?
So I graduated fellowship at the peak of the COVID pandemic. There was no better time to start doing house calls because that's when it was most needed, because people were afraid to come into contact with healthcare, whether it was a hospital coming to the office, but there were still so many patients that needed care. So that was a mixed blessing. Obviously, it was a horrible period of time, but there was a lot to be learned, and it kind of really lit the ignition and accelerated my thoughts in regards to how to bring this care into people's homes. And as I started seeing patients, my first patient ever was a house call. My first independent patient as an attending was a house call, and I slowly picked up all the little nifty tricks and techniques and strategies over the past 3 years as to how to incorporate a full-fledged cardiology practice in someone's home. So it was an interesting 3 years, and you know,
so COVID just kind of forced you to
forced
really hone your
skill. Exactly. And now I guess the predominant focus of my practice is in-home care. So a lot has, you know, we've developed a lot since that time.
And you know, my next question actually kind of fits a little bit, you know, together with the answer you just gave. But with the onset of, you know, COVID pandemic, how has the experience altered the way in which you and your physician colleagues provide care to patients? For example, via, you know, telemedicine, we're talking about visits. And what further developments do you foresee happening in the area of alternatives to traditional in-person care?
I'm actually very excited by what has emerged. So COVID, again, it was a terrible period of time. But one of the things it's taught me is that you don't need to see 5 separate providers in order to accomplish, you know, the particular feat at hand. And what I mean by that is you don't need to make 5 separate trips. You can still see all those providers. You just need to have one core provider that will be coordinating the care. So let me give you an example. I'm seeing a patient that's relatively homebound or finds it difficult to get out and see multiple providers. I say that's actually the most common scenario, where patients can go see providers, but it's technically challenging, whether it's transportation or mobility issues, but they may still need to see 2 or 3 different providers over the span of a few months. So how do I solve that problem? Through the technology of telemedicine. Because I've learned and met providers that are interested in the geriatric field, if I needed an endocrinologist, I can pull up an endocrinologist on a video conference call. I can review labs, I can review medications.
That's awesome.
Yeah, and the physical exam portion, I'm there in the room. You don't need to see the other doctor for that portion of it. I can tell them what I'm finding, and often we need their knowledge, we need their brain at that period of time, and we can accomplish that all through one visit. The same is true for patients that are, you know, more cardiac in nature. They may have pacemakers or defibrillators that need to be interrogated. I'm comfortable interrogating and checking pacemakers, but if there were a question, if there was something I need to address, I can pull up an electrophysiologist on the screen, I can show them the findings, and we can get an answer on the spot. And you know, that goes back to the question you brought up earlier. If you have a motivated team of providers that are interested in doing this, and that's the team that I've kind of really pulled together over the past few years, you can accomplish a lot and limit the amount of travel that needs to happen. And I think that's one of the silver linings of the COVID pandemic, is we found ways to optimize the patient encounter and incorporate more into the same amount of time.
I'm just curious, are those televisits billable for the physicians, do you know? Or?
So as of now, they are, and hopefully they will continue to be. So yeah, I think at this point, as far as I know, a televisit is still a televisit, and as long as it's documented appropriately, you can have those encounters. I would say that from the provider standpoint, they're less inclined to want to do that, because most providers, particularly cardiologists, we need to see the patient. You know, you need to listen to the lungs, you need to get the EKG, you need to auscultate the heart sounds. So it's an inseparable part of the visit.
Right.
But as long as I'm there, and let's say there was an endocrinologist or a rheumatologist, as long as someone's able to relay the physical exam findings, which I think any clinician would be able to do, you bridge the gap. And again, you accomplish more in the same amount of time, you make it more comprehensive. And the best part is not only does that limit the amount of travel, all the providers are there at the same time. We're all on the same page. So to the earlier point we brought up about having conversations in real time to optimize patient outcomes, it doesn't get much better than that. You have all your doctors in the room making a decision for you simultaneously. It's as optimal as it could be.
Amazing. You know, I really enjoyed this time. Thank you so much.
Thank you.
But before we go, are there any other words of wisdom that you'd like our audience to take away with them before we end, together today?
Yes. Don't forget to enjoy your life. Okay, it's very important that people don't forget. We have this one life. We can optimize all these little things. We can titrate medications.
I love that.
Yeah, but in the end, you live once. You have to enjoy your life and really never forget that. And that goes for the patients and their family members. We're all in this together, and the ultimate enjoyment of life, that needs to be held and kind of understood that that's what most of us want. So we have to take that into consideration with all our patients.
I absolutely love that. So enjoy your life, be intentional, and exercise.
Yes, exercise. Keep exercising.
Dr. Fridman, I have really enjoyed visiting with you here today and learning more about how to stay healthy. I must say it's highly unusual and truly wonderful that you offer in-home cardiology visits to your patients for whom it would be difficult to get a regular office visit. And I'm certain that this goes a long way towards maintaining and improving their well-being.
Well, thank you, Trevor. I had a great time and definitely a great discussion.
Thank you so much. I've also really learned a lot about the benefits and the limitations of medication, as well as the importance of having regular medication assessments, particularly for older patients who may be on a large number of medications. And hearing your insights about the role that exercise plays in maintaining well-being, even for older folks with mobility issues, has been truly inspiring. So how can viewers learn more about your approach to improving patients' cardiovascular health, and how can they find out more information about your practice?
Of course. Again, thank you for the great discussion today, Trevor. So the best way to learn more about me is to visit my website. You can get in contact with the practice. My website is davidfriedmanmd.com. And Fridman is spelled a bit unusual. There's no E, it's just one I. So it's David Fridman, F-R-I-D-M-A-N, MD.com. All our contact information is there, and I'd love to meet you guys at some point. Thank you so much, Trevor.
Thank you so much, Dr. Fridman. We appreciate you being here.
Thank you.
Lastly, I want to thank our viewers for watching today's program. Please stay tuned to PKRG-TV for upcoming episodes of our Wellbeing series.